Thank you for joining us for our Prioritizing Health Equity webinar, or this month's Chronic University. We are really glad to have you and to be taking on this important topic. This is obviously something that is a crucial thing for us to solve within the healthcare system. And when we talk about the things that affect patients, this is definitely at the center. So we want to talk about this in a lot of different ways. It's a very complex problem, as our healthcare system is a very complex system, but there's good progress being made. There's interesting work being made. And more importantly, there's an increase in awareness. And that's where sometimes we have to start. So I'm going to start out by introducing our panelists. We just have a terrific group of people here. Hi, Delegate Tran. We've got really wonderful folks, and we're so glad to have everybody here today. So we're going to talk about the patient experience. We're going to talk about the clinical research that's being done so that treatments can be effective in addressing health equity. And we're going to talk about some of the public policy ways that we can address health equity. So with that, I just want to say again, thanks to everybody for joining us today. And I'm going to start by introducing our panelists. Actually, I'm going to let them introduce themselves because we've just got really great histories with everybody. And so everyone on the panel, I'll call out names, and invite you to introduce yourself and your role and what you think of when you think of health equity. Again, this is such a broad topic and such a complex one, but I think that we'll see that there's a lot of interaction between all of these stories and how we can improve things for all the communities in our country. So as always, I want to start with the patient experience. CJ, could you kick us off, please?
Sure can. Good afternoon over in the East Coast and good morning in the West Coast. My name is CJ Walker and I am an ambassador for the CDC. I'm also a wife and a mom and also a person living with diabetes. And for me, health equity is really important to me because as an advocate, I try to ensure that everybody has access to the care that they need. So no matter the income, your race, your gender, we all have a human right to have access to healthcare.
Great. Thanks, CJ. Sydney, could you go next, please?
Definitely. Hi, everyone. My name is Sydney. I'm a patient advocate, and I was diagnosed with a rare autoimmune disease as a teenager, which is what kind of fuels my passion for advocacy. I'm also the operations director for a nonprofit called Generation Patient. We're an organization that was created and is entirely led by young adult patients. And we work to facilitate events, meetings, and online programs that empower young adults living with chronic and rare conditions. Speaking from the perspective of a young adult patient living with a mix of complex conditions, health equity, at least for me and those that I work with, really means access to prescription medications and treatment and care that they need to survive and retain their quality of life.
Great, thanks, Sydney. Dr. Ruiz White, could you go?
Yes, hello. So hello, everyone. Good morning, good afternoon. My name is Dr. Inez Ruiz White. I'm the R&D lead at Otsuka Pharmaceutical. We're a pharmaceutical company primarily in the therapeutic areas of CNS and nephrology, although we do other therapeutic areas such as infectious disease. And for me, health equity is essentially fair and equitable access, education, and treatment, diagnosis and treatment for all patients.
Great, thank you. Delegate Tran, absolutely, not least or last.
Thank you so much for having me. Hi, everyone. I'm Kathy Tran, and I represent the 42nd District in the Virginia House of Delegates. So parts of Southeast Southern Fairfax County, if you're familiar with Northern Virginia. And I'm a mom of 5 with my kids ranging in age from 21 months to 13 years. And Elise is home from preschool, so she might pop in during our conversation today. To me, health equity means that everyone, regardless of your gender, your race, your language ability, your ability to pay, your immigration status, where you live, that you are able to have high quality, affordable healthcare when you need it. And that includes prescription drugs as well. And so I really look forward to our conversation today and sharing what's been going on in Virginia.
Great, thank you. I do want to shout out Brian Dorn is running our webcast. And so if any panelists or audience members have any technical problems, please, you can message him directly. He's off screen, but ready to help. And Nathaniel, I'd like to introduce you. And Nathaniel's going to talk quietly because he's in a room with a sleeping baby. But we are very, very glad to have him as well. Nathaniel.
Sleeping no longer. So if you hear a little coo in the background, that's my 4-month-old son. But Nathaniel Brown, hello everybody. I'm the Director of Advocacy at the Chronic Disease Coalition. I help our ambassadors and our members connect with their legislators and do our advocacy work in all 50 states. And so very pleased to be here and think that this conversation is very important to me. Health equity is not only about access, but about outcomes. And I am I'm thrilled to be a small part of this conversation today. So thank you.
Great, thanks, Nathaniel. So just as a little matter of housekeeping for folks who are watching, feel free to put questions throughout, or you don't need to save them. We can, this is a very comfortable, easy conversation. I mean, may or may not be easy, but it's definitely not formal. So feel free to ask questions throughout, and I'll help to manage those. So you can use the Q&A or you can use the chat function, whichever is most comfortable for you. We don't have to use names for audience members if you just want to ask a question. So we want to have that threshold be as low as possible so that folks feel like asking questions. And you can ask general questions or you can ask questions of specific panelists and their experience. That's absolutely fine. Obviously, we won't tolerate, rudeness, profanity, slurs, any of that sort of thing. So, be polite. I know your grandparents are watching, and we'll get going on this. So I'm going to jump around a little bit, but Delegate Tran, you've led efforts in the Virginia legislature to improve some of those outcomes for patients as we've been looking for, specifically around long-term care and emergency care. Could you talk a little bit about what that looks like and where you saw the problem and how the policy sort of at least provides a little bit of solution?
No, thanks so much for that question. I'm going to take us back a little bit and then kind of delve into some of the, I want to kind of set the stage for some big picture changes we've made in Virginia that I think really help to get at a more equitable healthcare system, and then talk a little bit about some efforts I've pushed. But we passed Medicaid expansion, and that was a huge success in Virginia. It was many years in the making, even before I was first elected in 2017. We had patient advocates, advocates for low income, communities of color, advocates for immigrants, and advocates, all across. We had even the business community were really supportive as well to expand Medicaid. And at that time, we thought we would be able to have an additional 400,000 Virginians get healthcare coverage. And to date, we have 621,254 people who have signed up for healthcare under Medicaid expansion. And I want to talk a little bit about the chronic illnesses and diseases and how that intersects with Medicaid expansion. We just got some data in anticipation of this panel about the types of treatments that people have been able to receive because they have newly enrolled. And so you have 20% of people who were treated for high blood pressure. 10% treated for diabetes, 5% for asthma, 3% for COPD. I think that gives you an idea of the type of chronic illnesses that people were dealing with on a day in, day out basis that they were not able to get any type of treatment for. And so the fact that we were able to expand Medicaid, I think, has made significant progress in terms of making sure that we're able to address chronic illnesses amongst some of our most vulnerable individuals in Virginia. I think the second piece I want to chat about really quickly is what we're doing to help people who are aging at home and dealing with very different illnesses as well, and being able to do so in a dignified way with their family members and with the right support. We've made significant investments in our home health care aides and workers, making sure that they are getting in pay increases, that they have 5 days of sick leave. I know that's not a whole lot, but it was a big step for us, that they get some sick leave, that they're able to work overtime so that the person that they're taking care of can be able to better schedule that care and have more uninterrupted care. And so I think that is also a really important and significant step that we've been able to do to help people who are dealing with chronic illnesses be able to age in place in a dignified way. And so I think that's something I wanted to highlight. Mary Kay, the two bills I think that you were bringing up that I was focused on, one was around long-term care insurance and making sure that there's a little bit more transparency in the billing and price increases. And I think you have a lot of thoughts about that model, but premiums have just gone up, and in some cases significantly in the last handful of years. And we want to make sure that policyholders have the information they need to make good decisions about their plans when those increases are made, right? There's sometimes you get different options about which way to go now that you're facing an increase. And we know that type of planning is really essential for people as they age to make sure they have the appropriate level of care that they anticipate they're going to need, and having those kind of financial plans and insurance in place. And that's really important. And the other piece, and I think you're alluding to, is the work that we were doing around making sure that undocumented immigrant children also get care. So now that we've expanded Medicaid, we want to make sure that we're able to provide similar services to children who are undocumented, so that all kids, regardless of their immigration status, are getting taken care of, particularly when they're young, is to help ward off any potential long-term illnesses or be able to catch them early. And then the last thing I just want to add to this conversation is we are currently studying nursing home staffing ratios. And when I think about equity and aging, is making sure that some of our most vulnerable elderly Virginians are getting equitable care, quality care in their nursing facilities, and making sure that those facilities are staffed at the appropriate level, so that, that's good for both the staff as well as for the patients who are there. So that's some of the things that we're doing in Virginia.
That's great. And before I let you off the hook, Medicaid expansion for a lot of states has started happening, with the passage of the Affordable Care Act. Could you speak to how that impacted equity in Virginia, the Medicaid expansion, kind of what you all were seeing before expansion and what you saw afterwards?
Yeah. And I mean, I think on so many levels, I just talked to you a little bit about kind of, so more people are then eligible for Medicaid, meaning individuals who are low wealth and vulnerable individuals are now having healthcare coverage. And I just shared with you some of the data around, the types of illnesses they were dealing with, right? So I think that's also really important, but it means that the need was so much greater than we even had anticipated. We thought when we were expanding Medicaid, we were going to cover 400,000 Virginians. That was like the big number. And to date, I think I just read, it was like, it's over 600,000, right? And I think what COVID really shown was like, as the economy was facing its challenges, people were getting laid off, and they sought healthcare because they no longer had employer coverage. We had more people who were looking towards Medicaid. And I think, so I think that's a really important lifeline, literally lifeline for people in Virginia right now, and given the stresses of the pandemic as well. And so what's been really exciting is just to know I think with this data coming in and as it's updated, the total need in Virginia and the total types of chronic illnesses that people are facing and not getting care for. And so making sure that we're able to kind of shed light on that and the need, I think, long-term for our both, health system, our economy, and what it means for the community in terms of people actually getting the care they need when they need it, right? So that's been really exciting.
Yeah, I think it's so easy to we think so much when we think of healthcare as, us as a patient with a doctor, us as a patient with a nurse or other provider, but we forget that insurance is actually what opens the door to those people or closes the door, right?
Yeah.
Depending on your condition. And so that's why certainly a lot of our work is about expanding that access, whether it's to government programs or to private programs, and ensuring that those are meeting the need.
I think that worry about healthcare coverage and the worry about debt also prevents a lot of people from actually seeking care, right? So, I mean, that was an experience I had growing up. We had pretty, my parents had pretty decent healthcare, but I honestly don't remember all the wellness checkups. I don't think I went. Like now, I take all my kids to lots of wellness checkups, right? But I don't remember going as a child, and and so we've actually done a lot of work this year. I worked with Delegate Sally Hudson, Senator Barbara Favola, and Senator Ghazala Hashmi on medical debt to build on some work that we've done previously. Is one, to make sure that underinsured and uninsured individuals are being checked to see if they qualify for Medicaid, to see if they qualify for the hospital's financial aid programs, and then also making sure that charity care information is provided in other languages so that everybody, regardless of their ability to speak English, is getting the information they need so that they're not facing medical debt, right? And I know this is happening when people are in the healthcare system, but hopefully that as word trickles out, that we have these safeguards in place, that people will be less afraid of the potential debt and come in for care.
Yeah, 100%.
And I wanted to, sorry, Mary Kay, I wanted to just
jump
in and just follow up to that point, because to expand that not only to your healthcare as from a patient perspective, but also from a research perspective. To participate now, part of Medicaid, and starting from 2022, clinical trial costs can be covered. It's mandated that it can be covered under Medicaid. And this is the first ever. So now it also opens up now to those who have been uninsured, right? Who are low income and have limited insurance, where cost has been one of a recognized burden for participating in clinical trials. Now this is being covered. And then it now addresses back to some of the health inequities that came apart from clinical research. If you're not participating in a trial, we don't understand about the medications we're treating to those patients. And then we find out different adverse events later on, which becomes to different health inequities. But I think also clinical trials can be a way of treatment for many, right? And so we basically level set that a little bit now with from the bias of social economics to say that now that opportunity, right? We talk about our experiences. When I reach out to my family members, I always ask, have your doctor ever reached out to you about a clinical trial? And now that with COVID, clinical trials is like kind of a common table conversation now, right, with COVID. And so it's those things that we can hopefully make sure that from those biases that come from social economics, and let's be honest, it's also related to race and ethnic and health inequities as well from those populations. This now opens those opportunities. So it's great work that you're doing in Virginia. Kudos to you. I appreciate that. And I just wanted to make that note that how these things can even expand not only from health treatment, but again, to health research and medical research.
Well, let's kind of keep going on that. And as if you could expand on sort of what brought you into this work and what you see happening. And again, sort of that same sort of, here's the problem, here's how we're going to address it. Framing would be terrific, because I think this is a fascinating area, and a lot of us don't think about how clinical trials affect us differently depending on what socioeconomic and racial and gender groups we're in.
Absolutely. So first, I must say full disclosure, right? I'm representing my thoughts and opinions and not my company's. Have to kind of say that. But I am R&D lead of DE&I, and for us, right, DE&I, we understand that there is a lot of health inequities that come from various diverse populations, and we know that some of the underrepresented patient populations that are in clinical research are those from minorities from different race and ethnicities, basically age, social economics, and those with disabilities. And for us, when we really have to think about research or how we develop a treatment, right? It comes in phases. First, there's the research phase, when we first understand the pharmacological way the drug works, right? How it interacts, what receptors it's working, how is it triggering. We also have to understand how the disease works naturally, right? And then how we can intervene and overcome that. And so this the second part is then testing. We then look and develop different types of treatments, whether it's devices, vaccines, right? The products, pills, IV solutions, whatever that drug formulation or basically product formulation is, we then need to test that to ensure that we have true safety and efficacy for that. And then third, we need to make sure that from the operational point of view, that those patients have access and can get those treatments, right? So again, or do they have the means to see a doctor, be prescribed that medication, afford the medication to take it, and then be treated accordingly, and then understand how is that working. And so from those phases, there are various health inequities pretty much at every part of the phase. First phase, from a research perspective, if you don't have diverse populations you're studying in from your research, you're limiting to what you know about the disease. So in our genetic databases, we're very homogeneous when it comes to sort of race and ethnicity. So basically, when we understanding different pharmacological effects, there's limitations that now come from that. So now we're having a limited medical and scientific understanding of the disease, how it works in different backgrounds and patient populations, and then also different understanding of how our drug works towards that. So there's a lot of the inequities that we're trying to address, and many sponsors and industries trying to address, is expand now and make sure that those genetic databases are becoming heterogeneous. Do you have the appropriate age populations, pediatric samples versus those in elderly, right? Also, comorbidities is a diverse population or demographic we need to think about when we think diversity. Many times we think race, gender, right? Maybe sexual orientation, but comorbidities. If we know that, let's say, a percentage of our US populations have maybe these particular comorbidities, diabetes, high blood pressure, we need to understand then how that disease is affecting that in that comorbidity versus, let's say, a completely healthy, adult. And then what impact that could have on our treatment. So those are all things about how do we make our now databases a little bit more heterogeneous from that perspective. Second, now in our testing, we now know, and we've seen definitely from the learnings with COVID, but really, to be honest, from US, it's just been historically our history and nature that if from our trials, we primarily have done trials in white males. So we're very limiting in that. And now there's research, there's new guidance that just came out on April 13th, where the FDA is now giving guidance about sponsors in clinical research promoting and understanding and implementing a diversity plan. How are you ensuring that you're really reaching out to that diverse population your product is intended to treat? How are you going to enroll those patients? How are you going to study those patients appropriately? What are the appropriate metrics to do that? So now really that testing and is really good guidance that are coming out and initiatives to help with those health inequities. And then the second, which a lot of my policies and patient advocacy groups, I'm sure could follow, it's now you made the drug, but you still then have these health inequities to these access to the drug, right? Or the treatments of the drug. We know that in definitely various disease states and common ones we mentioned here, those are people are diagnosed in different diverse population, particularly in race and ethnicity, they get diagnosed later in stage, right? In their prognosis of disease, which means that they're basically diagnosed later in their stage and they could reach to end stage or final stages of the disease much faster than their sort of white cohorts. So these are those health inequities about what are the biases that our ACPs have. You talked about, Dr. Kathy, about making sure you have that representation at the nursing homes, right? So we understand that cultural competency is important to have those health equities. And so we know historically it's been those with the Black communities, they don't feel pain the same way, right? Black women have basically higher birth complications and death rates than we talk about white women. It's those from the biases that come from healthcare treatment on why that is. And so that second part is how we operationally make sure we have those health equities. Are we going in that community education and engagement? Are we ensuring equity in health literacy? Do we all understand what a clinical trial is, or how I take this medication, or how I should be self-diagnosing myself to maybe trigger and go to an HCP, right? We might be taking on things from my grandmother said this, oh, I just need to treat myself with this, right? It's those cultural traditions, or maybe they're not traditions, but practices, if you will, that we get inherited with. And we need to understand those different cultural inheritances and then how we sort of level set that and address that with health literacy. So that is some of how I define sort of the health inequities against in medical research and how different ways we can sort of address that.
That's fascinating to me how you look at the whole piece of it, from the drug development piece all the way through to the actual access piece, because I think you're right. There's so much, I mean, even just family baggage, right? Or just, distrust of the system, or distrust of, male doctors, and, so we all bring all this stuff to the table. And it's so exciting to see how people are thinking about that more holistically. CJ, I know you've had a lot of experience in the medical system, both the wonderful providers, of course, but also sort of the downside of health equity issues. Could you speak to what you've personally seen?
Yes, so with me, I deal with a lot of patients that would come to me for advice. And what I found so far is that a lot of patients, when they're first diagnosed with diabetes, for one, they're not given the information that they need. Many of them feel that they end up being lost, like even before their diagnosis. So they don't have anywhere to go. So as a result, many times they will come to online diabetes communities, which is where they can find me, as a last resort. So you have a lot of that. And then you also have a lot of diabetes stigma, and not just with, people of color and white people, but also just diagnosis itself between type 1, type 2, LADA. And there's like 15 different types of diabetes that are out there. But us patients tend to get categorized in certain areas, and then we're automatically assumed that, we are all treated the same way. And that's how diabetes stigma starts. So we see a lot of that. And I believe one way we can handle that is to first start rebuilding the trust between the provider and the patient. A lot of people of color tend to ignore being with a physician because they don't trust. It's a lack of trust. And that's been happening over the years and, through generations. So we need to start rebuilding that trust. within the doctor and the patient, and meet patients exactly where they are. So, for example, if you have a patient, that has a hard time and they don't have employment, maybe the doctors can actually connect with organizations in the local area to be able to help provide and guide that patient towards the right direction of getting a job, so they'll be able to afford the medications and things that they need. So even as being a resource and having those resources available to the patients will at least make a difference in how they manage their own chronic illnesses and diseases.
Mhm. I think that's so true, and so often, based on the medical education system, providers aren't always taught to really understand how those things impact different groups proportionally. When jobs start to go away, disproportionately, it's people of color who are losing their jobs. It's going to have quite, impacts on their health access as well as their health care and their general health status. All those things play in, and they don't always know that, depending on where they went to school or their age or just their openness to that education. So I
It's a
love
lack
that.
of trust. It's a lack of trust. And if they feel that they can't trust you, they're not going to tell you anything that's going on, with them, their family. And all of that makes a difference. And it's just, it just depends on how you as a provider treat your patient
That's
with
you.
respect and care and dignity.
Yeah. Sydney, you've got a perspective on this too, especially working with young people, but I think you've been in the patient advocacy space for a long time. You've heard where we are in the conversation. What does all this make you think about?
A couple of things actually. So, we were discussing health inequities in clinical research, and that made me think of, the greater need for further inclusion of adolescent and young adult patients in clinical trials, as well as more discussion and advocacy in terms of the unsustainable cost of prescription drugs, and how that affects young adult patients who are facing a lifetime of illness. And bringing more understanding to that financial burden of living with a lifelong illness from such an early age. And that unfortunately, the high cost of the medications that we need to survive and retain our quality of life have such a huge or pose such a huge threat to our future independence and livelihood, and how that affects us now and in the future.
Sydney, did you have a hard time getting treatment or getting a treatment plan that worked because you were younger than patients are typically with your condition?
I haven't experienced that exactly. Getting I guess getting like a certain drug because of my age. Is that what you mean?
Yeah, or just it wasn't applicable to you, or it just wasn't as useful for you as a younger patient as it might have been for an older patient. I think one of the things that triggers for me is impacts on fertility, for example. Drugs having different impacts and them not really thinking about how that might impact younger folks.
No, absolutely. It really hasn't been an issue of access as much as just a lot of unknowns. And like you said, because the research isn't there, we don't know how that's going to affect fertility. And a lot of doctors aren't even informed enough on the potential issues that a younger patient might have. So they don't know what questions to ask. And oftentimes they may suggest a drug without really understanding the implications or potential consequences that it could have on a young patient.
Yeah. Dr. Ruiz White, I bet you have some insight. I'm thinking also about long-term side effects that are you can endure for 20 years, may be harder when you're looking at being on a drug for 60 years. Are those things that you all think?
Absolutely. And we get into a little bit of a catch-22 in a way from that perspective, because what happens is, unfortunately, again, how we've done things historically we have to understand that that might not be the way we need to be doing research now and in the future. So historically, when we get drugs, when we file them with the health agencies, we do it generally from, again, a very healthy perspective. So right away, when we do pharmacological things, we only do it on males initially in first phase. We do not test women, again, from the issue of what impact could that have on fertility. Now, from the safety perspective, it makes sense because we say we don't know much about this and we don't want to, right, cause more harm. Our goal is to not to cause harm, but to treat and right, cause benefit, produce benefit of our drugs. And so we're supposed to ensure that the benefit outweighs the risk. The thing is, in practice, we have to understand the epidemiology of the drug and who is really are the patients. So then when we are past certain phases where we have a better understanding of the safety, phase 2, phase 3, we now need to be more open to ensure that we're now including more of these diverse patient populations. So including those in more pediatric, right, trials, or those with more childbearing of age or other factors. And so what happens, we don't do that. And so when a doctor wants to, I have a 20-year-old patient and I need to understand what impact this has. I understand that you did it on adults, but most of your work might have been in this age range, or what impact on childbearing. We may say, or maybe the child is even of 17, right? So not quite an adult, but can I give that? We'll say we did not study that. It's not labeled for it. So you have to make your own MD decision and what we call off-label use. So now the doctor, based on their education, based on what they think, will say, should I give this to my patient from an off-label use perspective? And is that going to basically promote that? And these are now decisions that are now on the individual and that limits access, right? So these are all the things that come with that. And yes, there isn't one answer fits all, but I think we now, as an industry, and really with healthcare, we have to understand it's not a yes and a no. We should never test this. It probably should be, when is more of the appropriate time to do that, and how do we do that? And again, we're showing safety, so that eventually, to your point, when now you have a 17-year-old and they're taking this drug 15 years, 20 years, primarily in their time span of being, right, their childbearing years, we understand what impact that's going to eventually have. Many times we go, I don't know, but we have to do that research to explain that. And I think what now companies are thinking about, and the agencies are thinking about, okay, now maybe at phase 3, I'm going to make sure you have a small cohort of patients that represent this demographic from that perspective. And so now we at least got some information we can share with our healthcare providers and share with the community in general. So I think those are things we're moving towards. And again, it is disease specific, but just some thoughts there.
Yeah, well, it seems like the FDA rules, the regulatory rules, are going to help all researchers, research development industry move more into that space. So it's not just voluntary, diversity and inclusion, but it's a standard practice for everybody, which seems beneficial. And that's going to allow me to jump back to Delegate Tran to talk a little bit about some of the other things in Virginia, or even that you see nationally, sort of doing that same thing of just like giving everybody a way to level up and have better health equity outcomes. What else do you see out there as being key to this work?
Can you hear me? I put that down a little bit further away. All right, hold on. We have 3 kids awake. Okay. I just, one thing I wanted to highlight was, and we haven't talked, I think, about this particular aspect, is people with disabilities and access to care. And I wanted to, thinking through like a patient bill of rights. And we passed in 2021 a bill that came to address a need that came to my attention through working with some constituents. And at the height of COVID, you'll probably remember there was a lot of limits in terms of who can come into a hospital. It was most often just the patient. And so I had constituents, many moms and my fierce mom groups who had adult children with intellectual or developmental disabilities. And because they were adult children, their rights are different than if they were under 18 and could bring a parent into the hospital during this time. And so these families were making really difficult decisions as to whether or not to even seek medical care, because for their children, many of them were nonverbal. The idea of like letting them go into the hospital alone without somebody with them to help ensure the right care or provide any type of services like, helping with eating, helping with toileting, just, and other types of services was really gut wrenching. And so, and this was an experience they had pre-COVID, but was exacerbated, right? The access to coming into the hospital with their loved ones. So we passed a bill that guaranteed every single person with a disability in Virginia the ability, the ability to bring in a designated support person with them when they come into the hospital, whether that's emergency care or you need if you're admitted and you need longer term care. And clearly the hospital can put in guardrails, like you can't go into the operating room, right? But it gives you the ability to stay beyond visiting hours. And I've continued to get emails from people all over Virginia, not just in my district, for whom this continues to be an issue. Even though we passed the law, it's like the affirmation and the training that staff need to make sure they understand what are the policies in Virginia, because people who are like, I have filled out all this paperwork. I have the proof that for my father, I am his designated support person. His doctors filled out all this paperwork. Can you please help me? And it shouldn't be that hard, right? Like, we should make it easier. And I think about that in terms of an equity piece that we don't, maybe not might be the thing that jumps out the most at you, but for so many families, it's even seeking care is hard because of these other concerns about whether or not they can have somebody accompany them. So I thought I was really proud of that work. And I think it's something that I hope is a model for other states in terms of making sure that every single person can come in, to get care who needs it because of this one piece around support. I just wanted to highlight that in terms of something a little bit different than what we've talked about today.
No, I think that's huge. Access, that is part of a holistic look at access to the healthcare system. And it makes me want to ask, I didn't prepare this question, but Sydney or CJ, whoever wants to jump in first. Delegate Tran mentioned paperwork, and I've worked with hospitals before, and paperwork is a huge aspect of equity for a broad variety of reasons, language only being one of them, right? There's just sort of educational levels, there's style of bureaucratic writing that is not, normal. It's not accessible. And so because it's not accessible, it affects different people in different ways. And so when we talk about like access to, as Delegate Tran mentioned, charity care, in healthcare situations, or even applying for Medicaid when it's newly open, those can all be barriers to care that are felt unevenly in our communities. So Sydney or CJ, can you speak to your experience in that at all, or how you might have seen other people wrestle with it? Make it real for us.
To be honest, I haven't had too much experience with it, but, as a mom, and I'm a part of the PTA, and when we have different types of events school-wide, we do have a number of Hispanic parents, and when we present different aspects or different things, they have a hard time understanding. So they don't have somebody that's alongside them to interpret what's going on. Many times it could be the student themselves that are helping their parents understand what's going on. And I believe that one way we can actually address that is to make sure that we have people that are relatable to that patient, to help them translate what's happening and convert it into a language that they understand.
Mhm.
So at least that's a little bit what I can gain, but I haven't really had that much experience yet.
Sydney, do you want to speak to that for young people? Because I think, I certainly didn't know how to read insurance forms when I was young.
Absolutely. Yeah, yeah. I've dealt with this personally, and I know a lot of, we work with a lot of people. We're all going through this transition from pediatric to adult care, and that transition can be extremely difficult. And especially, once you turn 18, all of a sudden they don't want to, like, if you're not, whether you're navigating insurance or other systems like maybe Social Security, all these systems that kind of touch healthcare, it can be really, really hard. And even for me, my mom worked in insurance, so she was able to help me navigate things a little bit and understand, but every individual case is so different. So what applies to me may not apply to somebody else. And even having a parent in that field only helps so much, because I think also being a sick kid, like you don't have the capacity to handle all the phone calls and all the paperwork and everything that you need to do, let alone the understanding. And then when your parents try to help, they confront a lot of obstacles because they don't want to talk, or the person, I guess, on the other
Right.
side doesn't want to talk to them. They want to talk to the patient. And I know a lot of parents that have expressed, frustration with that, as well as, young patients.
That's great. Thank you. So we're in
Mary,
the,
can I?
yeah, please.
Can I make a comment about I feel like the several times where we've tried to work through, do you make something accessible online or a notice on the wall? Oh, thank you. A notice on the wall or a handout, right? And I feel like the hospital association, like, I feel like wall space is, maximum real estate, right? And it's really hard to get that notice on the wall. But then if you push for paper, then who's going to be printing out all this paperwork? And, like, do patients want big stacks of paperwork? Who's reading that? But if you make it online only, I also feel like there are some barriers to making sure people know it's online and can read it. And, and so, like, I think that's been really hard to navigate. It's how do you make sure the information is available in a way, whether we haven't even gotten to the language translations yet, right? But like just making sure that information is available, whether it's available to the patient or available to patient advocates who could then help make that connection. And I think that's something that is still really needs to be kind of looked at. And it's almost for us in Virginia, like on a policy by policy basis, which ends up where what you can negotiate, but that's been a tricky issue.
Yeah. Well, and as a patient, you walk into an ER or, anywhere, it's a wall of words and they're big words. And I'm sick. I just want somebody to make me better. So it's, it's a huge thing. So I'm going to use our last 15 minutes to talk, to give everybody a little space to talk about what they see going forward, where they see, where you see some of the challenges and where you see some of the opportunities. And if there's any last minute questions from the audience that we haven't, pulled out of folks, please use this time now. But in the meantime, I'm going to start with Sydney. So, what do you see in the world? What do you see going forward? What do you hope we can fix when it comes to health equity?
So really just kind of reiterating something I said earlier was I know for young adult patients facing decades of life where they, their life and quality of life depend on medications, and the high cost of those medications is crucial. And I think there needs to be more progress and discussions around the creating more sustainable prices for pharmaceutical and prescription medications. because they pose a significant threat to the future independence and livelihood for patients who are going to be living their entire lives with a condition.
That's great. Thank you, Sydney. CJ?
I definitely agree with Sydney for one. One thing that I really want to see is more opportunities, not just for people who are on lower income, but middle class families like myself who are not able to afford, well, we make too much for Medicaid and Medicare, but insurance is through the roof for us.
Right.
And I really haven't seen a lot of solutions for that, but I wish that I receive a lot more of that. And that's part of the problem now, especially, you know, when we talk about things like the insulin cap and things like that. It helps the people, you know, with lower income, but it's not helping those, you know, who work hard for their families. And that's not fair. And we really need to address that, because I've read recently like 37% of people of color, even though we've advanced in being able to have insurance and whatnot, they still don't have it. And it could be because of immigration status. It could be any other reason, or just, you know, income itself. There's many reasons that are. So just being able to see more work being done with people who are uninsured because they just can't afford the insurance, and they make too much for Medicaid. So yeah, that's a huge problem that I wish it would be addressed more.
Yeah, I think that is a huge thing, that insured and underinsured or high deductible plans that put so much pressure on a working family, and, you know, maybe help you out when you've been hit by a car, but for chronic diseases, you know, you're going to spend that $4,000, and that's a lot to spend before your insurance kicks in. So I think that's a good call out, CJ. Thank you, especially for our chronic disease community. It's, you know, you just know you're going to have to spend it, and it's a huge impact. Delegate Tran.
I think one of the things we really need to be addressing is the workforce issues, you know, whether it is the nursing shortages, mental health and behavioral health services providers. And you know, I think it really is a big issue in terms of how do we make sure that as we're expanding care, that there are service, you know, that they're actual caregivers who are ready to fulfill the need. And I think a part of that is, you know, we were just having yesterday was a long day. So Wednesday morning, a conversation around the nursing homes staffing issue I mentioned earlier, and that whole industry, like other aspects of healthcare, is having a hard time finding workers. I think pay is a big issue, and some of these jobs in healthcare are filled by women of color and immigrant women. And so when we're looking at kind of the care side of equity, I think we also need to look at equity on the workforce side as well. So how do we make sure that we're able to train, attract, and retain the best? And that's going to get at, you know, good pay, jobs with career ladders, workplace safety, and benefits. And I think really holistically being able to address that across the board for the healthcare industry is going to help affect some of these other issues we're talking about expanding access to care.
Absolutely agree. Those are huge. Dr. Ruiz White, what are you seeing? What are you optimistic about?
So again, speaking from my arena of research and development, I think what I've been very optimistic about is first the acceptance and the real truth in conversations about health inequities. Health inequities is nothing really new. We've known it for decades, and we know that these health disparities have occurred across different patient populations. But it was always kind of from this sense of, well, research is still progressing. You know, we didn't quite take it as like a need in a sense. I think for whatever reason, you know, COVID has really blew that up. and made people understand that this is a need, a requirement that we have to address. And so I'm optimistic because I think the industry as a whole has now sort of said, really have just apologized to the public, sorry, and we will do better. And so I think that has, the first thing is to me, is I'm optimistic about that. Some initiatives have been about that access, awareness of clinical trials, the importance of diversity, putting in regulations, guidances. So I think that has been very encouraging to ensure that we're really moving and changing the way we think about how we should be doing medical research, and then ensuring, again, we have that diversity, equity, and inclusion. I think some challenges we still have is about cultural representation and the impact that still has. I think there's still some significant work that needs to be done to ensure that we have proper representation at with our clinical trial staffing, our investigators, assessors, and how we evaluate our data. I do think that, we need to continue that progress there. And I look forward to, hopefully in the upcoming years, we'll do just that. But I think there's been great work with just sort of accepting, identifying potential ideas and guidances to how sponsors and organizations can ensure that the patients in their trials really represent the patients they're intending to treat.
That's great. Nathaniel, you've been quiet and a little busy.
Sorry, I've had to be off and on.
But you also work in a bunch of different states as our policy director across the country. So I'm just wanted to give you a chance to comment on things that you're seeing that in the policy health equity space that even other states are taking on.
Yeah, I mean, for me, this conversation has reinforced, the role of advocacy organizations like ours, really trying to elevate that patient voice. I've spoken about this before, but it's much more impactful when decision makers can hear, actual patient perspectives instead of a one-pager that we would draft, right? Like it's elevating and making sure that they are a legitimate and credible part of the policymaking process. And I think about our policy platform and how there's the equity impacts of things like restrictions on telehealth, things like restrictions on copay assistance, states that haven't expanded Medigap, and so this conversation has really got me thinking through with more of an equity lens and more of that patient-centered approach. And so, that's as far as, our advocacy work is concerned, we'll continue to do that. But this has really been an exceptional conversation.
Yeah, I think it'll be interesting, I think, for all of us in all of our different fields and perspectives to watch what happens as a result of COVID. I think that there will be, a broad variety of things. One is we know that the impact was disproportionate in some communities rather than others, but also there's not walls between us. We're all affected. When some of us are sick, we're all sick. And so pretending that health equity doesn't affect everybody in this country, or economic equity doesn't affect everybody in this country, I think has just been shown to be foolish. I mean, I'm not a researcher, but it just seems dumb to me. So we can now stop pretending that we're all separate, but also understand that the hits come disproportionately and unevenly, and that we can and should use the tools that we have, research, policy, advocacy, to even that up. And even the work that CJ and Sydney do, I think, is really important, is that one-on-one connections with other patients, to provide that allyship, and to address the uncomfortableness and sometimes hard conversations we have to have with providers about things, and then push them to look for treatments that are going to work better for us, and that didn't just work well on a cohort of 40-year-old white men, but that worked better for us and had advantages for us specifically. So And again, I just want to thank everybody and free everybody up for the top of the hour, but this has been an incredible conversation, and I really value everybody's perspective, and thank you for your time that you've given to us. We will share lots of pieces of this conversation through our social media channels, through our newsletters. So if you weren't able to watch the whole thing, keep an eye out for that. We put the recording up for everybody. These are free, and they're monthly, and maybe even more than monthly sometimes. So we want to make this a place where everybody can come and learn without barrier. So again, thank you, CJ and Dr. Ruiz White and Delegate Tran. And I think that Sydney jumped off, but or maybe I'm just not seeing her because my screen changed. But thank you all so much for coming and being a part of this. Thank you.
Bye, everyone.
Have a great
Thank you.
whatever.
Thank you,
time.
everyone.
So much.
Have a good Thursday and a good weekend. Bye.